Hi there, I'm Dr. Robert McLean. I'm a spine surgeon here in Cleveland, Ohio, and I'm here today to talk to you about your back and your neck, how you can keep them healthy and fit, and what your doctors can do when they're not. I hope you find this discussion interesting and informative, and at the end, if you do find that there's something you need to talk to a doctor about specifically, I'll give you my contact information so that you can get a hold of me and find out what we can do to help you out. So I hope you find this interesting and you enjoy the presentation. Today, I'd like to talk specifically about neck and arm pain and an alternative to fusion surgery that you might find right for you if you're someone who's otherwise been told you need to have a fusion. Disc replacement surgery, or cervical disc arthroplasty, is a relatively new procedure that's proven very effective for patients who otherwise might need a fusion for their neck. Whether you're just curious and think this topic might be interesting, or you're a patient with a real neck pain problem, I hope you'll find this interesting and informative information. Now, if you do have a neck or back problem that you need to have help with, and you live in our area, please consider giving my office a call at the number below. Disc replacement surgery is a well-established alternative to fusion. It's used for the treatment of severe neck and arm pain caused by disc degeneration or herniation in the neck, and sometimes disc arthroplasty or disc replacement can be used for the same kinds of problems in the lumbar spine. Cervical disc arthroplasty is specifically intended for patients with cervical disc disease, which is usually caused by either disc degeneration or disc herniation. It can happen after an accident or just with wear and tear changes over the years. And that degenerative process is one that has caused changes in the normal disc biology. The injured disc isn't a good shock absorber anymore. It doesn't maintain good alignment or motion. And when you do move and you do change positions, it often causes severe pain. The abnormal disc, when it moves awkwardly or abnormally, can cause significant sharp neck pain. It can cause neck spasm, stiffness, headaches, and it can cause a lot of problems with function, difficulty sleeping, or pain with activity, exercise, work, or recreation. Patients with disc degeneration also can have a protruding disc. The injured disc can push out into the cervical canal, put pressure on the spinal cord or the nerve roots, and that can cause severe arm pain, numbness, and tingling. That's called radiculopathy. And radiculopathy can cause that severe burning pain that runs down the arm into the hand. It can cause a deep aching, toothache pain, and it can cause numbness and even weakness in the extremities. Sometimes the disc can protrude all the way into the canal and put pressure on the spinal cord. That's a more serious problem and sometimes a little harder to sort out. Patients with spinal cord compression often experience nothing more than changes in manual dexterity. They have trouble buttoning buttons, or they have problems walking a straight line. They lose track of their balance and find that they're unsteady on their feet. Sometimes they don't have any pain, even though the cord can be under a lot of pressure, and that's a serious problem. Spinal cord compression is called myelopathy, and patients with radiculopathy or with myelopathy, these are patients that often will not get benefit with just physical therapy and non-operative care, and those patients may require some surgical treatment. If we see severe myelopathy, that can be a strong indication for surgical treatment, whether the patient is experiencing much pain or not. So when disc degeneration or herniation or degeneration causes neck pain and stiffness, severe arm pain, numbness, tingling, weakness, or symptoms of myelopathy that just don't improve with non-operative care, that's when surgery may be necessary. The good news is, disc surgery can be very reliable and successful in relieving symptoms of arm pain, neck pain, stiffness, and interference with function. The surgical treatment, whether it's a fusion or whether it's a disc replacement, does a great job of relieving neck pain, relieving arm pain, restoring function, and it can eliminate the numbness, tingling, and arm symptoms that a vast majority of patients suffer from. Most patients, whether they undergo a disc replacement or a fusion procedure, get a great outcome. That means that they get back to work and get back to recreation without pain medications, with a low risk of complications and a high degree of satisfaction. For these patients, surgery is a good solution to pain that just isn't improving with non-operative care. But getting the right surgery is an important decision. Now, whether we're talking about fusion or disc replacement, the important part of the operation is the decompression. That's taking the pressure off the nerves. And that's exactly the same for the fusion procedure and the disc replacement procedure. A lot of the parts of these operations are essentially the same. The discectomy, the removal of the disc, and the part where we physically take the pressure off the nerves, that's the same for both operations. Relief of nerve pain and weakness after we do that, that's about the same. And even the early relief of neck pain is the same between the two kinds of operations. The big problem comes in fusion somewhere down the line. Fusion takes two different bones and gets them to grow together into one. It takes two moving segments and makes them stiff, eliminating pain by eliminating abnormal motion. The problem is stiffening that one level of the spine puts increased strain on the other levels. We've eliminated motion and eliminated pain, but the other levels have to take up that motion. They have to handle the loads of the spine. They have to handle the range of motion that the original injured level used to do. And that puts increased strain on adjacent levels. Increased strain at those levels above and below the injured level results in what we call adjacent level disease. That's wear and tear change at another level of the spine that was previously okay. Adjacent level disease can cause symptoms just like the original disc injury, and that can cause significant pain, neck pain, stiffness, arm pain, numbness and tingling, and even weakness and instability like we saw for the first operation. So adjacent level disease is a big problem, and it sometimes occurs years down the road. Cervical disc replacement was developed specifically to avoid adjacent level disease. Disc replacement is designed to fill the gap left behind after discectomy with an implant that restores normal disc height and alignment, allows about a small amount of flexion and extension, side-to-side motion and rotation, and restores motion similar to what your healthy disc had originally allowed, taking the pressure off the adjacent levels whenever you do normal daily routines and regular motion and activity. The whole goal of disc replacement surgery is to maintain motion at the original injured level and prevent this adjacent level degeneration from ever happening. And that's what we've seen in long-term trials and in my own surgical patients. Disc arthroplasty has become a really important option for fit, active patients with cervical disc disease who otherwise would have to have a fusion. So when is total disc arthroplasty the right choice for you? Let's talk about how we make our surgical decisions. So, how is your doctor going to make a decision about whether you need surgery or not? Well, first of all, they're going to take an excellent history, and that's what we've been talking about when we talk about the symptoms that you're having, when they came on, how long you've been dealing with them, whether you're having more neck pain or more arm pain, and whether there was a specific injury or something that set this all off. That's what the doctor refers to as the history, and it's sort of the story of your pain. Next thing, your doctor should do a good physical examination. And physical examination is looking at the range of motion of your neck, how it flexes and extends, rotates side to side, how your neurologic function is. He's going to test, or she's going to test, all your muscle function, grip strength, arm strength, and your leg strength. They're going to look at reflexes and sensations, so they should test how you feel with your fingers, whether you can tell the difference between sharp and dull sort of sensations, and they may want to look at how you walk, look at your gait and balance, because pressure on the spinal cord can significantly affect how your balance is and how you stand and how you walk. If you start losing your balance and you can't walk a straight line because of something going on in your neck, it's called ataxia, and ataxia is an important sign of spinal cord compression. Next, your doctor's going to look at imaging studies, and we have 3 different kinds of imaging studies that we may look at in any case of neck pain or back pain. We look at x-rays. X-rays are the pictures of the bones. They show the bones really well. They can show whether they're moving abnormally if we do flexion and extension views. They show a lot of the alignment of the spine, but they don't show us much of the soft tissues. The other thing we can look at is an MRI. MRI doesn't show the bone very well, but it shows the discs, the tissues of the spinal canal, and any of the soft tissues in the bodies very well. Your doctor may also ask for a CT scan. CT scan is a more sophisticated way of looking at the bones. In this particular case, we see normal bones here, we see normal disc spaces here, but as you can see, the levels here are narrowed. There's a little bit lighter line here, that's denser bone, and there's a little bone spur here. So this patient has disc degeneration at 2 levels of the cervical spine. In addition to the plain X-ray, we may want to look at an MRI. An MRI is a picture of the soft tissues of the spine, and it shows us those bones again, but what you're seeing here is bone marrow, not the actual bone. It shows us the spinal cord, which in this case has no pressure on it, and you see fluid in front of the back of the spinal cord, and then you see the discs. And normal healthy discs have a little bulge to them, but there's no protrusion. And in this case, where I showed you the arthritic levels before, now we see that the disc space is narrowed. It looks a little ratty compared to its normal neighbors, and you see a disc protrusion at each one of these levels. And these disc protrusions may push on the spinal cord, not in this case, or on the nerves as they exit to go down the arm. And this disc protrusion or disc herniation is the thing that causes the arm pain and the symptoms of numbness and tingling in the arm. It's important to know that we don't just operate based on the X-rays or the MRI. We look at the X-rays, we look at the MRI, and make sure that what we're seeing explains the patient's symptoms. We'll always see some sort of degeneration in any patient over the age of about 45. But when a patient has specific arm pain, specific neck pain symptoms, and we see something like this, this is a large disc herniation. We see it pressing back into the spinal cord. It's narrowing the spinal canal and putting pressure on the cord itself, and it's also going to be pinching the nerve root that's going out into the arm. That all makes sense in terms of lining up this level of herniation with the patient's symptoms. Now, this is something we may need to treat. And in fact, in this patient, because of the large disc herniation here, the disc space collapse, the extent of this particular patient's neck pain and arm pain, surgery is the thing to do. And then in a case like this, the likelihood of a good outcome is really very high. Whether we do a fusion or a disc replacement surgery, this is a patient that will benefit from surgical treatment. So when we've got a disc herniation, when we've got arm pain and neck pain, and we have a patient that's just not getting better with physical therapy or conservative therapy, surgery does become a good option for pain relief. What we're looking at here is a cross-section of that MRI we were just looking at a minute ago. Cross-section means that the image was taken as though we cut right through the disc itself. And what this shows is a large protrusion. This dark spot here, that's all disc material. That's supposed to be up here. This more gray area, that's the spinal cord, and it should be filling this space with no pressure on it. Over here, you see a little bit of a light area. Over here you don't see as much. That's because this disc protrusion is pinching the nerve as it comes out here to go out into the patient's arm. This disc herniation is producing cord compression and arm pain or radiculopathy and needs to be treated. Now the options are 2 really for this kind of a herniation, and they usually involve going through the front of the neck. Some surgeons will operate on the right, others on the left. That's not the important point. The important point is to get to the front of the cervical spine. This is a model of the cervical spine showing the spinous processes, the part that you can touch on the back of your neck, the side of the vertebrae, and then up in front is a ligamentous tissue, and then the discs at each level. And to take this pressure off the spinal cord, we go in, we cut away the tissue in the front, we take this disc material out and physically take that disc herniation away from the spinal cord and away from the nerve root. That relieves the pressure, but it also relieves the pain very quickly and very reliably. What do we do after we've taken all this tissue out though? If you think about it, we've now made a gap between the bones above and the bones below. And treating that has involved one of 2 techniques. Traditionally, we've put a spacer or a piece of bone in here to restore height, hold the vertebrae apart, and generally that was a piece of bone in the past. Then we'd put a plate on here and we'd fuse the spine. The bones above would grow into the bones below. It would become one stiff, solid bone, which relieved a lot of pain and was a very effective treatment, still is if it's the right thing to do. But the problem is, once this segment becomes very stiff, it puts strain on the specimen, the vertebrae above and below, the disc spaces above and below, and you start getting wear and tear changes down the road that can be quite severe. Now, how do we avoid developing this adjacent level disease down the road? Well, that's where disc replacement surgery or disc arthroplasty has become most beneficial. Patients nowadays, if they have a satisfactory disc space to start with, if they've got motion in the neck, we want to preserve that motion. And disc replacement allows us to do the same operation I just described in terms of taking the disc out and taking the pressure off the nerves and off the spinal cord, but it allows us to put a spacer in between the vertebrae that will provide good alignment, good stability, but also allows a little bit of motion and flexion and extension, side to side bending, and rotation. And what that does is it relieves the stress that would be applied above or below at the other levels. And in theory and in practice now, we've been able to show that that reduces the incidence, the likelihood of developing adjacent segment disease or degeneration at another level. Disc arthroplasty has been around for about 15 years, actually longer than that in Europe, but we've only really been using it in a large number of patients in the last few years. I had the privilege and the opportunity to participate in one of the early clinical trials at the Cleveland Clinic some years ago, and I've been following my patients for about 15 years, actually a little longer than that now. So I've seen the benefits of disc arthroplasty or disc replacement, and I've seen that they have lasted, that the results are durable, and that patients are able to get back to a high level of function with a very normal functioning neck. That's the same thing we've seen in large studies and trials, and if you look at the research that's been done and the follow-up studies, you see that in large numbers of patients, we've gotten those kind of results. It's important to know that disc replacement surgery is not experimental. It's not investigational. And while some insurance companies in the past didn't want to support it very well, it's now been shown to be, well, less expensive, which is something that they're happy about, but it's also better for patients in terms of patient satisfaction, complication rates, and reoperation rates. In many cases, much better, particularly when two levels have to be treated. So disc arthroplasty is now one of the go-to solutions for young, healthy, fit patients who still have residual motion. In other words, the neck still has the potential to move, who don't have severe arthritis in the joints in the back of the neck, which would hurt even after you did a disc replacement, and who have degenerative changes, disc herniations, that can be treated through an anterior approach and discectomy. Patients who have infections, patients who have tumors, fractures, things like that. This isn't a solution for those kinds of problems, but it's a very good solution for the degenerative disc disease, a very good solution for disc herniation and nerve root compression, and it works very well for selected patients. If you are from our area and you do have a problem that you need to have help with, or if you've been told you need to have surgery and you're just looking for another opinion, please consider giving my office a call at the number below. And if you find this talk interesting and you want to know more about back and neck care, about orthopedic spine surgery in general, or about my practice in particular, please check out my website at www.spinesurgerycleveland.com. That's www.spinesurgerycleveland.com. Thank you for listening.